where does the general consensus lie around fatty liver? It's like you just diagnose it and move on.
Yeah, basically. I mean, I connected to the dots a long time ago.
Welcome to today's episode of the Medical Disruptor. This is a show where I bring you the most incredible clinicians from around the globe, trailblazers who are breaking the mold and transforming healthcare to help people like you feel better, live healthier, and reclaim control of your well-being. Let's dive in. On today's episode, we have Dr. Joshi. She's an MD and a GI hepatologist at one of the largest urban hospitals in Canada. She's flipping the script on fatty liver disease. She's calling out the system for not helping patients reverse their fatty liver, and she's not waiting for the system to catch up. Through education and advocacy, she's helping people take control of their health and prevent liver disease before it's too late. This is our first episode on fatty liver, so you don't want to miss it. Dr. Supriya Joshi, I am so excited that you're here with us today.
Well, thank you for having me. I've been looking forward to this all week. So thank you, Doctor.
Likewise. Okay, so for our audience, we are going to talk about fatty liver, I promise. But I always have to start my podcast with kind of knowing like how we got here. I like introducing us to disruptors and seeing how we first drank the Kool-Aid and then how we undid some of the learning. So tell us a little bit about first, you're an MD, what you do, the schooling that you had before you fell off the cliff.
Yeah, well, I actually love this whole concept of being a medical disruptor. I never looked at myself in that light. So I'm going to say thank you for calling me that, including me in the. So very traditional training, undergraduate physiology, medical school. I did internal medicine, gastroenterology, and the subspecialty in liver disease. Still in school a very long time. I taught at an academic center for a while and then moved on to full-time community clinical practice where I do get involved with some trainee education as well. And I'm one of the largest urban hospitals in Canada. And given the burden of liver disease, that's been my role at my institution to help my colleagues and myself manage these patients in our community. And being in practice now for more than 20 years, I got to see the natural evolution of chronic liver disease, and tides were shifting. When I first started, it was all like hepatitis B, hepatitis C, and alcohol. And there's still autoimmune and other less common diseases people don't hear about. But over the decade, I'm seeing progressive end-stage liver disease from metabolic liver disease, which is formerly called fatty liver or non-alcoholic liver disease.
Wait, don't go there yet.
I won't go there. Just to the name. And so what I was seeing, and I currently have multiple patients that are either being listed for transplant, but the alternative is palliative care. And these people are in their 50s, early 60s. And that to me is what's really been heartbreaking, because when it comes down to metabolic liver disease, it's a preventable condition. And when I talked to people, they had no idea how they were living their life was not in good health and not with a good plan. I realized that many of them thought, my parents had diabetes, my parents have obesity. They figure it's their genetic, medical destiny to end up with these same conditions, and to make them realize, you actually can, we do have our genetic potential, but you can do a lot with trying to arm yourself with education and effort and consistency and pivot and change your destiny. It doesn't have to be disease.
Absolutely. Absolutely.
So that's how I got on this path and self-learned many things, because as you know, I didn't learn this in training, not the lifestyle part.
Okay. So here's my question though. You went to school, and we both know that in school, we don't study nutrition outside of like vitamin C deficiency, scurvy. And you went to school, you went to all the conferences, you did all the thing. What was the moment though? What made you decide that there's more to it than just, okay, great, diagnosed, transplant, or like, there had to have been something, because many of your colleagues don't go down this road. What was the thing that turned it for you?
Well, one of the issues with the most common liver disease I take care of, which is like, metabolic liver disease, I had no medicine to give these patients. There was no treatment. Like we have for autoimmune liver disease, you need steroids and immunosuppressants. If you have liver failure, I give you a diuretic. So the underlying cause I came to realize was all of things in their lifestyle. And initially I'd be like, okay, lose weight. I'll see you in 6 months. And that was a very common discharge kind of advice.
Yeah.
When I saw them in 6 months, they were worse.
They were worse.
So I said, well, what did you do? Well, nothing. I don't know how to lose weight. And when I realized people were saying, I don't know what to do. I started, and I knew what I did, because I have always been very much I've been driven myself to maintain a healthy lifestyle. I was very lucky. My mother's a registered nurse, so she did this from our family, and I learned that from her. And then I've continued to learn how to make myself healthy with activity and diet, nutrition, and good sleep sort of thing. So I realized I think I have to share what I know in detail with my patients. And obviously our learning is evolving. Like what I do today is different than what I did 20 years
Oh,
ago.
yeah. Oh, yeah.
Right? I'm not like running on the treadmill anymore. And I've shifted gears being 50 plus. So learning that, I was able to give details to my patients, and I started to see progress.
Oh my God. Yeah. So let me ask you this before we go on to fatty liver. What about your colleagues, generally speaking, nobody specific, obviously? Do they come to the same conclusion around fatty liver, or are they like where does the general consensus lie around fatty liver? It's like you just diagnose it and move on?
Yeah, basically. I mean, I connected to the dots a long time ago. I think I realized very early on this is a metabolic condition. And I think from a lot of my colleagues, so there's a lot of problems we're all seeing in our offices, and we got to see patients quickly. It's an overburdened healthcare system. So, and I don't think we view ourselves, we're not dietitians.
Ah, I see. I see. So
That's
you're
not
like,
our job.
not my job.
Hey, I'm here to diagnose your disease, go lose weight, bye, next patient.
Yes.
I think it's about how we look at what is medical care, and it's not lifestyle driven. Even primary care physicians are very much, we're disease focused because we're trained identifying disease.
Correct.
Lifestyle is not in our education, armament. So, but I really passionately wanted my patients to have success, I had to learn it and I had to convey it. And obviously I'm not the best at it. I do my best, but you can really make it quick. You get a very good sense of someone's barometer for lifestyle within
Absolutely.
what do you eat for breakfast? What do you put for your tea?
Are we starting with Lucky Charms?
And then go on. It's a 5-minute spiel, and that's all it takes for most people.
So your distinction then, this is really important because, earlier before we started, I know you're not in functional medicine yet, but your distinction was really important. So like in functional medicine, what is very clear to us that conventional medicine starts from disease on, which is really important. You want it. This is never an either or, it's both. And then a lot of what we do in functional medicine is what can we manage before the disease. But in your case, very uniquely, I really like this distinction, is that you recognize the disease and your colleagues recognize the disease, but the conversation is like, how are you defining what you do after disease? Because to your point, there's no meds, and to which case many of your colleagues, not in a mean way, are like, okay, well, there's no medication. There's nothing to do. It's up to the patient. Figure it out. Go to a nutritionist. Next.
Yeah. And starting out, but further to that, I mean, because if they're coming to see a liver or GI specialist, the question to us is, do you have significant liver disease? And if you have no liver damage or fibrosis, don't worry about it. Your liver's fine. But my take on that is,
that's such a good context.
Fibrosis, but you have fat in your liver that's not supposed to be there, and that means insulin resistance. So while you will never need to come back and see me to manage your liver failure, I'm going to give you this advice now, because if you don't pivot, you will more than likely develop type 2 diabetes, hypertension, cardiovascular disease, dementia, and all the things that go with that. So that's where I think the separation is. I see the significance of the lipid in their fat and what that means for them, because it's so common, like 40 to 50% of the population has it. And it's been so normalized, because if I tell a patient, they go, oh yeah, everyone has for a decade, no one's anything.
Okay. Whoa. That context you just provided was so important, because I just had a conversation with one of my patients about cholesterol. And I went to my cardiologist, said it was fine. I was like, listen to me. This is a cardiologist that's used to heart attacks and stent and bypasses. So it's true you're not there. In his world, your cholesterol is nothing. See you next year. Come when you're clogged. But right. And it's so important in the context, because sometimes I send to specialists, and the specialists are so used to seeing the sickest of the sick that someone coming in this early stages, you get a false sense as a patient. You can get a false sense of security, like, oh, my specialist said I'm fine. Yeah, you're fine because you're not there. Oh, this is such important context. I really love this because.
So yeah, that's how I view it a little bit differently. And in addition, I would see my patients 15 plus years ago. I had my type 2 diabetics who were on a lot of insulin as their treatment to bring down their blood sugars. And I see them year after year and watch them get progressive liver disease, cirrhosis. I'm thinking, please stop giving them more insulin. Whereas the diabetic education centers would be like, okay, you're eating that, your blood sugar's higher, just give yourself more insulin.
Right. Oh my God.
That person, if you modify what you're taking in and you shift your macronutrients, you give less bread and bagels and more protein, you won't need more insulin.
Absolutely.
So that was the thing that really used to annoy me a lot. And patients I would share with my fellow colleagues in endocrinology, because their treatment was controlling their blood sugar, sort of, but it was worsening their metabolic disease.
Of course, because if you're to begin with insulin resistant, how much is insulin going to help you? Walk our audience for a moment of, before we get to how we get to fatty liver, what happens, like the fatty liver to cirrhosis, like walk us through the spectrum of like nothing to here.
Sure. So the liver should be pink and smooth and vibrant. That sounds kind of funny, but that liver should just be clean. And so liver fat is not supposed to be there. And I look at it more as a mechanism of survival, contrasting to living in a world of excess and sedentariness. So liver fat was designed to be a storage form of energy. So if you come to basic science and physics and chemistry, energy is transferable. It's not created or destroyed. It's just transferred. So when people consume energy in their food or their drink, and it goes down into our esophagus, our stomach, into our small intestine, where our enzymes, our gut hormones signal each other to break down this product and let you absorb it. So when these micronutrients now get absorbed from the gut into your venous system and get delivered, your liver sees all of this. And when there's a lot of glucose, which we need to live, when there's too much of it, though, it can lead to disease. So I'm sure I know you know this, but for that glucose to get into our cell to power it, it needs to be signaled for that gate to open. And the gate, in a simple form, is opened by insulin. So blood glucose goes up, insulin goes up. Insulin signals the gate to open, glucose goes in, happy cell. But when it's too much, our other cells no longer respond to that insulin stimulus, and that's called insulin resistance. So now that glucose needs to go somewhere. So that glucose gets converted into liver fat through a process called de novo lipogenesis that specifically occurs in the liver. And so the liver is storing this fat, this energy as fat, waiting for you to need it, waiting for famine, waiting for fast. And if famine or fast happened, then again, through our glycogen and, glycogenolysis, through multiple processes, that fat is now converted back to usable energy for your cells in super simple terms.
Yes, I love this. It's
now you live in a world of excess and I'm too busy to exercise. I'm sitting at my computer all day long and go home, make dinner and go sit on the couch. When that's the repetitive cycle and you keep feeding, your liver fat keeps on accumulating. So liver fat is like step one. So that liver fat's there, but it's not still injuring your liver. So a second episode or event happens. I don't think we know enough what this second event is. This is called the two-hit hypothesis, that all of a sudden something happens to the liver and inflammation starts. And when that inflammation starts, and that could be a drug injury, it could be an illness, could be alcohol, could
stress,
be some unknown stress, then you get liver cell inflammation and activation of stellate cells, fibroblasts, and a lot of oxidative injury. And that's what leads to the development of liver fibrosis. Now, people know the liver can regenerate itself, and absolutely can, but only up to a certain point. So if whatever's injuring the liver is allowed to keep on continuing, every episode of inflammation can lead to fibrosis. And this repeated injury over years can lead to a completely scarred nodule, and that's called liver cirrhosis or stage 4 fibrosis. And if, again, the injury is allowed to keep continuing, then people will develop decompensated liver disease, which is liver failure and need for transplant, or they're at risk of liver cancer. So, but up to stage 4, it's certainly been shown that people can reverse their liver disease and their fibrosis if
the cause of stop. Yeah.
Alcohol, diet, lifestyle, autoimmune disease.
Even fibrosis, but not cirrhosis.
Well, it can be improved upon, but the cancer risk is still there, less so than if it had not been reversed a little bit. It's less common. It can,
less common.
Less common.
what I love about what you described, and I always like to rewrap it for the audience, is that initial fatty liver is actually your body trying to help you out. It's like, okay, we have all this excess stuff. You fed us too much. And so we're going to pack it up. We're going to store it for later because I'm sure you're going to need it one day. And, if we weren't living the standard American life, maybe you would need it one day. But instead, we just keep storing. We keep giving it a message of storing. It keeps doing that until eventually it becomes a problem, as you said. And that inflammation, just generally speaking, anyone who's already living that lifestyle is already in a state of inflammation. Right? If you're smoking and alcohol and not moving and stress, you're already, so it doesn't take much to light this match.
Could very well be. And in addition, that liver fat that's still there, even if the liver inflammation hasn't progressed, other hormones are kicked in and you get hepatic insulin resistance. Further communicates with your pancreas, your dysfunctional adipose tissue. It leads to muscle insulin resistance. So there's a whole, circuit of communication going on once hepatic insulin resistance starts. So the liver might be fine in terms of long-term, survival.
Yeah.
But that systemic insulin resistance has started, which is going to perpetuate chronic metabolic disease, potentially shorten lifespan. And if you are lucky to reach an older age, you will more likely be on a multitude of medications.
Yeah. So, all right. So two things I want to say. So one is that very clear for anyone listening that insulin resistance and this type of fatty liver can only happen if you have excess amount of food. This type of fatty liver.
Correct. Incorrect types of foods. And I still call that malnourishment.
100%. It's malnourished because you're not getting the nutrients in it.
God, it's liquid nutrition. I'm going to call it nutrition. Is consuming various liquids and too much not so healthy food with not enough exercise.
Now, this is what's called non-alcoholic fatty liver disease. Is that correct?
Correct.
Okay. And is this relatively new that we have to create this term non-alcoholic? Because it used to be the case that you associated liver disease with alcohol. And now all of a sudden we have this non-alcoholic, right? That distinction, I imagine, had to happen because this is a relatively newer trend.
Absolutely. So if you look at data from, looking at prevalence of obesity and overweight in North American individuals, this all really started in the 70s. So prior to that, when people had fat in their liver, they were drinking alcohol. And so now you move to the 1980s and people didn't understand the connection between overweight and liver fat. It was still presumed, you must be drinking alcohol. And that kind of perpetuated within medicine. And that was quite stigmatizing for many people who never drank alcohol, but yet they have fat in the liver. So then it became recognized, so when I was then in training, in the late 1990s, early 2000s, that there's something in the nutrition and obesity and weight issues that are leading to this. And then we recognized that, the macronutrient consumption became divergent in the US when low-fat guidelines came out. Significant intake and sugar, refined carbohydrates just started to peak. And correlating that with more sedentary behaviors and processed foods and, high fructose corn syrup, being everywhere, I think the dots started to get connected. But only super recently, just last year, in fact, the whole nomenclature changed because the word alcoholic liver disease and non-alcoholic was still very stigmatizing.
Oh, fair.
And it didn't connect the dots for what led to the disease. So that's why, as of last year, global renaming of this condition, which is called MASLD or MASLD, which is metabolic dysfunction associated steatotic liver disease.
Wow. Okay.
That is the new name worldwide for fat in your liver. And then if there's the inflammatory fibrotic component, it's called MASH, metabolic dysfunction associated steatohepatitis. Okay, so it's MASH that can lead to cirrhosis. MASLD is you've got liver fat and you have insulin resistance.
Wow, they couldn't come up with a shooter acronym? Really? They had
I 100% agree. It's a mouthful. So I'm trying to get better at practicing saying.
Yeah.
Saying it like that. But they're all one and the same conditions. And even within MASLD, there's a subcategory of people who still consume alcohol. And
Sure.
they have metabolic disease and alcohol. steatotic liver disease.
Wow.
So there's all these overlays now of what is leading cause for that individual.
Is this is kind of, I have no idea what the answer is to this question. So I'm sure you do, but is the alcohol liver disease, isn't it the same pathway in that it's excess of glucose, or is there something specific about alcohol that makes it different?
Alcohol is directly a toxin.
Oh, because I got you.
You get the acetaldehyde. It's a direct toxin to liver cells and other cells in the body. So if you drink alcohol, depending on how you mix it, you could get a double hit.
Sure.
If you mix it with a ginger ale and a Coke and you add your alcohol, you got that crazy level amount of high fructose corn syrup
And the direct toxin.
the alcohol.
Okay.
So those mixed drinks.
So in the liver world, this information that the Surgeon General just came out with in January was no surprise for the liver world.
Oh, no surprise.
No surprise. So do hepatologists not drink alcohol at all?
I would say they still do. I would say way less. Personally, in my own journey, being over 50 and realizing I don't metabolize the same way I used to. I mean, there was really no data or guidance on alcohol because we know everyone used to think, oh yeah, 2 drinks a day was
It's great. Good for
and
your
I
heart.
really enjoyed. I'm that person that never even finished a glass of wine when I was out. I've just always been that way. But as we age, we don't want to handle it as well due to declining muscle mass, due to declining enzymes, weight, and then enzymes to metabolize alcohol. So that's one part of just growing older that helps you not really enjoy the drink the same way. So, but since all these guidelines have come out, and Canada made a statement, a year and a half ago before the US Surgeon General did. So Canada made a statement a year and a half ago saying that under 2 drinks of alcohol a week is what's called low risk drinking. Anything more than 3 a week, and you've increased your risk of multiple cancers and cardiovascular disease and dementia. So Canada did that a little bit earlier. And now the US has now made a full statement that none is of any benefit.
Yes, none is any benefit, which is really new.
Which is really new for everyone to digest. But from the liver side of things, we always knew it wasn't that great. But I always had a sense that 2 drinks a day, that's still too much. Because
I always thought that too. 2 a day is a lot.
I used to be considered acceptable, right?
I know.
It's a pivot for a lot of people to wrap their head around.
When the Surgeon General came out of this, and we're a little off topic, but when it came out, it struck me as this is exactly how it was with cigarettes in the 20s, where you thought that a little bit was okay. In fact, sometimes it was recommended, and it was recommended even for pregnant women for a while. It was recommended to calm you down, especially if it had menthol in it. And there was a time where it was treated the same way alcohol is treated now. Not only did they said, oh, it's too much is not good, but a little bit is not only just okay, but at some point it was thought to be beneficial. And then eventually they realized, no, you shouldn't smoke at all. And I feel like the same thing happened with alcohol. Like, well, too much is too much, but then and you get less and less, but 2 a day, 2 a week. And now they're like, yeah, we were wrong.
Oh, yeah. I hope they did the same for high fructose corn syrup. I mean, amount of stuff.
Oh my God.
Teenagers. And, I can see what kids are drinking and consuming. And
it's a mess.
It's a mess. You've got 15% of children with the same issue of metabolic liver disease as kids,
I know, it's crazy. I know I see a lot. I remember years ago, I was in a pediatric conference and someone was like, why are we testing cholesterol in kids? And I was like, what are you talking about? Half of my kids are like obese. I have to test. I'm testing them the way I test adults, like what's happening with them. Prediabetes, like it was a regular panel. Okay, so I'm a patient and I go for my annual. And maybe I'm like a little bit overweight. I don't consider myself very overweight. I go on my annual and I see slightly elevated liver enzymes. First, I'm going to ask you to tell us what that means. So then my primary says to me, we should probably go get like an ultrasound. And the ultrasound says I have a fatty liver. So I have slightly elevated liver enzymes. Maybe it's in the 60s or 70s and I have fatty liver. First of all, tell me what that means to me. And then tell me what I should do about it.
Sure. So if you have liver fat and enzymes are elevated, I guess the discussion for this is a change. Are you on new medications? Are you consuming any alcohol? If so, how much? And are you taking any herbal supplements? So I just want to get a good sense of what else they could be taking, because there's a lot of stuff that's not regulated that people think, oh, this is great for me. And they can consume them. Because I've seen multiple cases of liver injury from herbal things. And then you need to follow that up. So the next step would be making sure that, you've done a viral hepatitis screen. Is this patient born somewhere else? I mean, risk factors for viral hepatitis. Are they a baby boomer? Do they get a blood transfusion? That sort of thing. So you'd screen for hepatitis C.
I have none of that. Everything is screened.
Perfect, which is perfect. Then we talk about the dietary history, But tell me about yourself. Like, what do you eat for breakfast? So I'll ask you, what do you have for breakfast today?
Oh, so I'm just going to say, bagel and cream cheese and a cup of coffee, 2 sugars. I think I would die if I
So that is a very common York.
That's a very common one, yeah.
You add in some cereal with apple cinnamon in there.
Oh, yes. Some Lucky Charms for the
or sweetened or sweetened yogurt versus plain Greek yogurt, So that would be the typical breakfast and a glass of juice.
Oh, yes. The orange juice is so good for you.
Right. So that would be your breakfast. Okay. How many times a day do you have coffee or tea?
Oh, okay. Why coffee tea? Because of the sugar or something else about coffee tea?
What are your habits? Because I see people.
Oh, yeah. I have at least
a amount of sugar.
Yeah, at least 5 cups of coffee a day, let's say.
Yeah, because it got to keep you energized, right?
Sure.
Yeah. And so what's your exercise pattern like?
Oh, not really. Don't exercise at all.
And what kind of job do you do again? I can't remember.
I'm in the office all day long.
So are you sitting or do you have a desk that goes up and down?
No, I sit. I have sciatica. I can't do it
Got it. And do you have any access to stairs? Are you walking anywhere and you're at work?
My office is very high, so we take the elevator.
Got it. And when you come home, what's your work hours like?
9 to 5, but I have a commute. So I have a commute in the morning and then a commute at night. And then I'm going to, come home. We have dinner, the whole family. And then, sometimes I walk the dog and then we watch TV and then we go to sleep.
God, and how's your sleep?
Oh, it's terrible. I can't sleep. I think I need Ambien. I'm going to ask for some Ambien.
And what's your...
I'm just imagining someone coming to this podcast and I'm saying, Dr. Reed just said she has Ambien. Tell me again.
Yeah, and what's your evening like? You've made dinner. What did you have for dinner last night?
Pasta, a glass of wine, typical, I'm Italian, so I have my pasta. I hear this all the time. I have my pasta, some bread, maybe some chicken parm, a glass of wine, it's good for your heart. Yeah. And and then we just, watch TV.
Yeah, are you snacking while you watch TV?
Yeah, a little bit, nothing crazy. Some popcorn, maybe some potato chips.
God, and then you're off.
That's a good question.
But just
that not like nothing. That took 2 minutes.
Yeah, that's all it takes. And now I have a good sense of what your habits are.
And then what? So what do I do next?
So if am I a liver person or am I a primary care person taking care of you? Which one am I?
Well, this is you. Like, what is so unique about what you do that so your colleagues would be like, great, here's maybe a referral to a nutritionist, figure it out, see you in 6 months.
Yeah.
What do you do?
So I will then explain to them a few different areas that they could be mindful awareness of, so they can start it today.
Tell us.
What I would say, so first of all, I would suggest, so your breakfast, I know you're making this, if you're in a rush in the morning, have you ever thought of having eggs for breakfast? Have you thought about maybe not having the juice or weaning yourself off the sugar in your coffee? I would explain to them that a bagel is not low cal, like some people think. It actually is a very dense, refined carbohydrate. And for some people, that could be their whole daily quota of carbs for the day, or exceeds it even.
Yeah.
So I would then explain to them, I have a whole handout of everybody, teach them how to read a label. So they'll know that 4 grams of sugar is 1 teaspoon and what the WHO recommendations are on added sugar intake. So I would explain breakfast. I would just generally explain that when they have their lunch and dinner, it should be primarily vegetables and protein. I would explain that sometimes the sequence of how they eat can make a difference. So starting with your vegetables and your protein. And for them, have your carb, have a smaller amount at the end. And I would also encourage them, with your family, go out for a 30-minute walk or 20-minute walk after you eat and minimize the evening snacking and address the wine, how that's no longer considered a safe, recommended thing to do. And that might even help with the sleep because alcohol disrupts REM sleep. Alcohol is a diuretic and might make you pee in the middle of the night, another reason to make you get up. It may also worsen your anxiety and depression. So if you have those tendencies. So I would address these issues with this patient, give them my handout. I would send them with some investigation to ensure I rule it out other causes of liver disease. Yeah. And in terms of predicting fibrosis, I would address that as well based on their blood work. And I would calculate a FIB4. So I would plug in their numbers so it's available on any easy app that most healthcare providers have, where you plug in your AST, your platelet, and your age, it spits out a number, whether that's low risk of liver fibrosis or high risk of liver fibrosis. And I would also probably order a liver scan to get a good sense of, again, fibrosis, but also to show the patient how much liver fat do they have, which is typically categorized as mild, moderate, and severe. Because now that we have this utility, it's non-invasive, but it really gives the person, for the most part, a good sense of what's going on. And I find that it does tend to motivate people because they really want to see that liver fat progress.
Absolutely. You know what I love? I love your advice because, first of all, you didn't talk about weight at all. You didn't tell me I have to lose weight.
I don't do it.
You know, and I love that. I try to do that too. I'm like, I don't care how much you weigh. I certainly have thinner people with, I can't even say the new NAFLD yet, the metabolic one. Mazzled. I certainly have it. So I love that we didn't talk about weight, didn't say, why don't you lose 5 pounds? Nothing. And it seemed really reasonable. You didn't tell me, don't eat the bagel or don't eat. It's like, can we maybe get rid of the juice? Can we maybe lower the little bit of the sugar? And awareness around the bagel, that's like everything for the day, if not more. Maybe a 30-minute walk. You didn't tell me you have to do high intensity workout. Like, you didn't tell me I have to join a gym or buy a new outfit. Like, it was really like manageable, bite-sized recommendations that, just as I'm listening to you, would make people out there might think that won't make a difference. That is going to make such a huge difference. Right? Like, also just not drinking your sugar is already going to make such a huge difference.
I agree with you. I think telling people that to go run is just, it's too overwhelming. They're like, I can't even do it. So just getting up and walking as a regular thing is a huge thing. It's like many patients don't even, or they live the life you just described, right?
Yeah.
And for people in the office, I recommend for everyone, if I try, exercise snacks, it's a quick little, 1 minute every 1 to 2 hours, just do something of some kind of movements.
Exercise snacks is great. I never heard that term, but I love that idea. I do that all the time. I have a gym in my house, and like if I'm between podcasts, I'll just go do something for 5-10 minutes because sometimes an hour is impossible. But that's huge.
Yeah, just take 10 squats, or there's a staircase in your office building. Just go up and down a few times.
Yeah. Honestly, just squats by the table is like amazing.
Yeah. So little ideas to kind of see, because you don't know what works for everybody. So I
love that.
I try my best to provide them with like a toolbox, a toolkit.
Yeah.
The faster.
I love that.
This will result. And the more consistent you are, you will see differences, but it just takes time. And I tell people, it took decades for you to
get to when that turn is around.
Not going to go away in most cases next week.
Correct.
Chip away at it.
Chip away at it.
You'll be a new person in 6 to 12 months.
And there's no 60, 30, 90-day protocol. There's no supplements you should take. There was no, don't go crazy, paleo, vegan, carnivore, like nothing. It's just small, steady things, which I really
whatever works for you, whatever type of diet works for you. But in terms of supplements, though, I do recommend a few because, I live in Canada. So most North Americans are vitamin D deficient.
100%.
That vitamin D is involved with liver fat genesis and in insulin and in glucose metabolism. So I do recommend, if they have fatty liver, vitamin D 2000 IU daily, and I recommend magnesium glycinate at bedtime, which can help with the sleep and the relaxation. Yeah. And as people go lower carb, they can get leg cramps because you're peeing out a lot of magnesium.
True.
So that can also help, and it helps with the intracellular mechanisms of vitamin D doing its work.
Love.
So that's pretty much, I try to keep it as simple as possible for people, and there's nothing that replaces the consistent work.
100%. And you mentioned something at least twice in this podcast, and I would want this to flesh out. Doing this can help prevent Alzheimer's. Tell our audience why.
Well, I'm not a neurologist, but I'm learning myself and knowing that our brain is plastic, meaning it's reactive and it responds and it can still be improved upon versus our old understanding out your brain, your neurons are there and that's it.
Right.
Well, so we know that muscle stimulation can help with reducing the risks of dementia, as can sauna, as can minimizing blood sugar. So maintaining a holistically good active lifestyle can help the brain remain healthy. So I don't know a whole lot more about it because I haven't done deep dives into the science, but I see enough of it that I believe it. And I'm not taking the chance. So
100%. And there's a great book from Dr. Dale Bredesen. He's on my podcast. He's coming on again next week, and where he talks about the end of Alzheimer's. And one of the things there is that Alzheimer's is considered type 3 diabetes. So,
Correct.
right. So we're talking about neuroinflammation. It's an inflamed brain. And so again, everything you described with this insulin resistant overload, like it's not just in the liver, it's everywhere. And if that's not balanced, that's going to affect your brain. So if there's a part of you listening that's like, all right, it's fatty livers a little bit, everybody has a fatty liver. People are really scared of Alzheimer's. And I bring it up because sometimes that's the motivator. I'm scared of Alzheimer's too. I think, I do better than most standard Americans. But even with that, when I feel like, oh, I don't feel like doing this today, the thing that motivates me to get out of bed sometimes, or the thing that motivates me not to eat the thing, is because I'm constantly thinking about Alzheimer's. I'm like, well, I don't want this because it might affect my brain. So I bring it up because sometimes that's the reason to like go to orange juice in the morning. Really, this orange juice is going to lead to Alzheimer's? Yeah. If you continue this way, yes. Okay, breaking news, orange juice causes Alzheimer's. I definitely didn't say that, but within the context of everything we said.
Absolutely, because you want to be, we're all busy, growing up, first of all, getting an occupation, finding a purpose in life, having a family, taking care of your parents, like the sandwich generation.
Yes.
And what I see very commonly is by the time people reach that golden age, I can relax, enjoy my life, they get diseased.
Yes.
And I see it so often. As I was saying, people that are 50s, 60s, like when I'm referring them for transplant or they're not going to make it.
So young.
It's very young because they're also not fit for surgery, some of them. There's such bad brittle diabetes, that heart disease already. So they're the operative risk. So being consistent in all of these spheres of the pillars of lifestyle medicine, you want to really do whatever you can, each pillar, not perfection, but consistency to allow yourself to age well. We call that health span.
Yeah.
So I want to be 80 on 10 medications. I'm going to be 80 only on my vitamin D and my magnesium.
Yes.
And my menopause replacement therapy.
I'm so glad you said that.
To live well, right?
I'm so glad you said that.
I'm an older mom. I want to be able to be there with my kids when they have kids, I hope.
100%. Like asterisk, huge fan of HRT. So glad you said that.
But that and liver disease, there's a total correlation.
No, my God, you have to say this because I always talk about HRT and I don't think I always talk about the brain and the bones and the heart. We never talked about the liver and HRT, hormone replacement therapy. Go.
Perimenopausal women and postmenopausal women have 2.4 times the risk of having metabolic liver disease compared to premenopausal women. And we know what's happening. Estrogen is declining and insulin resistance is coming up. So it's not a big surprise that I see a doubling of women with metabolic liver disease after age 50, under age 50 men. And so I couldn't believe that we as women almost need to train for menopause, meaning we have to start in our 30s. I know this sounds like militant, but I really mean it well, meaning you have to look, if you want to have an easier time when you're going through menopause, get your strength, watch your nutrition, maximize the spheres of your life and your good sleep. And I know it's hard because most people in their 30s are still busted at work.
Yeah, working a career.
But being mindful of it to start in your mid 30s. And then by the time perimenopause comes along, you're ready. You've got a consistent pattern of habits that will help you flourish in those years. And, and understanding that like the WPSA was just negligent in women's healthcare. And so not to be afraid of it and know that if you're a good candidate for it, whether or not you have vasomotor symptoms, there's
say that again about the negligent in women's healthcare.
Well, it's scared and not getting everybody.
Say that whole sentence. Tell everybody what you just meant.
What I mean is that the WHI study was a study that looked at hormone replacement therapy in menopausal women. And there were innumerable amount of flaws with that study and just correlations were made without actually demonstrating good causality. And there was women who were smoking, had their risk factors or higher doses of medications, and there was no uniform dose of medications. So it led to a whole generation of doctors, including my generation, to be terrified of
hormones.
Giving women hormones. Men get testosterone.
Sure.
One's afraid of giving women anything, and yet women, the number one cause of death in women is like cardiovascular disease. So, it can prevent, bone loss, dementia risk, heart disease risks, even reducing the risks of breast cancer. So I think there's a lot of benefit to it. So, but people have to come to that circle on their own and be comfortable, right? We're not forcing things down people's throats.
Yes.
But people have to understand where they're at, and there's treatment for symptoms. And then there's long-term gain.
100%. 100%. This is not just about hot flashes. Regardless, you need this. Unless there's a contraindication.
Correct.
I feel like we need to start our progesterone at 40s. And then as soon as we can, our estrogen. And we don't have to wait for postmenopause to start.
No, you don't. And you have to do your own research and find yourself a healthcare provider that understands menopause, is NAM certified, and can educate you and guide you through this journey, because it does not need to be so miserable. And sleep. You need good sleep.
You need good sleep
the next day.
And you can't sleep if your progesterone's low. Oh my God. This makes me crazy. I'm so glad you said this. I know this wasn't where we were going, but where we got there. Because I never connected to liver disease before, which is really, it's another piece of it. Because all of a sudden you have liver disease. You're like, what? I've been eating the same way. Yeah. But now you don't have some of that protection that was helping you along. Oh my God.
And we know that, menopause replacement therapy can help insulin resistance. We know that.
Yes.
So I think it's worth a strategy or an offer before someone needs medications for their complications of insulin resistance that could still develop.
Sure.
So I think it's important, but a good foundation of pivoting for lifestyle, because everyone's habits are learned from their own upbringing. It's not that our parents were wrong. They just were misinformed. They didn't know.
Right.
Thought that convenience drive-through food at Burger King was great for dinner.
And TV dinners were great.
So it's a different generation. And so we now have to pivot to that our own young ones and families learn. So one thing I do talk to when I have the adult who's my patient, I say, this is not just for you. This toolkit is for your family. Because I want your kids to learn a different habit.
I love this so much. Oh my God, this is so good.
Well, it's generational health.
It's generational health.
It's generational health.
Yeah. And I see the difference. I see the difference in my kids are college age. The drinking is not the same as it was for they're just not as into it. Generally speaking, it's a different culture. They kind of already are yeah. That's really interesting. Is there anything else you want to tell our audience that maybe I forgot to ask you?
No, I think
okay.
Not actually.
That's good.
The pillars are: read your label, cut back on sugar and refined carbohydrates. We're not saying none. No one's going into food prison.
No.
But enjoy your life, but it's pivoting now. It's, I believe, worth it for having a more functional, happier life, active life when you're older.
Yeah. And I think you said by 30, I read it somewhere, we always think midlife is 40s and 50s, but if you're thinking of living, till 80, 40 is your midlife. 50 midlife means you're living to 100. God bless if that's your midlife. But our midlife is really our 30s and our 40s.
Yeah.
It's not 50s and 60s.
Turning 100 next month. Can you believe it?
Who is?
I have an aunt turning 100.
God bless.
Turning 100. I know, right?
That's amazing. Okay, so then you are the only one I know who's midlife right now at 50.
Yes, well, I'm beyond.
Well, I was just saying, to your point of starting early, it's not really early. That's midlife. 30 and 40 is midlife, not 50. We have our numbers wrong. Dr. Joshi, how could people... So please tell me.
You hope people that surround themselves with other positive connections. Right? That's also really important. I've been so fortunate to have an amazing partner that said, go work out. Go do what you think. They know. That it's always been that way. I really hope and I pray that everyone else has that same support systems in their homes.
It's true.
Because you need that, because it's hard to take care of a whole family, come home, cook, plan, all of it. It's a lot. You need to have a support system around you, whether it's hired help or partner or someone.
No, that's true. That's true. I'm blessed. My partner and I both have the same mission and vision, but I do hear from a lot of women who are not supported at home. And then when their partners are coming home, they don't want them to go to the gym or something. So there is that. So back to what you were saying, those little squatting, you don't need to leave the house for. Going up and down the stairs, you don't leave the house for. Removing that orange juice or removing the sugar, you don't have to leave the house for. So there are still, for anyone listening, I really can't, and I don't have a supportive partner. Those small little changes that you described, you need no one for.
Correct. They're free.
They're free, and you don't need to leave the house. And you can hold, if you have a little baby, you can hold the baby and do it. Or if you're taking, like, there's so much you could do there. So I'm glad you brought that up. That is amazing.
Yeah. And even just with financial issues, people can save money, but just not buying all this junk stuff.
They're not buying all this junk. Yes.
Save so much money.
So much money. Dr. Joshi, tell everyone how they can reach you, because everyone's coming to Canada now.
I guess I might do. So they can find me on liverhealthmd.com. I'm launching my site very shortly. I'm on Instagram, liverhealthmd. People can follow along for my regular posts. I try to do about 3 a week to provide people with evidence-based information to help them with their liver disease and metabolic health.
Love this so much.
Hopefully I'll soon be embarking on some one-on-one coaching and some webinars. And I just educate the masses and let's prevent chronic metabolic disease. That's my mission.
Hopefully by the time this podcast comes out, because it'll be a few weeks, your website will be up. So it'll be perfect timing. It'll be like, we love that. Dr. Joshi, you tied so many things that I didn't know needed to be tied, and really brought another dimension to this. And I'm sure our audience appreciates it. Thank you so much for your time.
Thank you for having me. It was super fun.
Of course. Thank you for tuning into the Medical Disruptor. If you want to dive deeper into these topics, grab a copy of my book. It's called It's Not in Your Head, and it's packed with insights to help you take charge of your health. For free access to my video library, head over to the drefratlamondre.com/courses. And if you're looking to work with me one-on-one, I do have a waiting list where you can apply. And if you're a nurse practitioner looking for courses to level up your clinical confidence, visit our website at egprep.com. Don't forget to subscribe, share this episode, and leave a review. It helps us reach more disruptors like you. Until next time, keep questioning, keep learning, and keep disrupting.